Hello, everybody. Good morning, good evening, good day. My name is Julian Chun. I'm working at the CCB Markus Krankenhaus in Frankfurt, Germany. Welcome to day 2 of Rhythm Interventions Online 2022. Yesterday, we had, I believe, a fantastic first day that focused on ablation and occlusion. We had cases transmitted from Frankfurt, Arkansas, and London. And you joined us. Well over 2,500 participants attending yesterday. You engaged, asked questions, participated in polls, and hopefully found it highly informative. The initial feedback was fantastic. Today, the focus is mapping and imaging. Today, we have another, I believe, fantastic program in store. There are 3 live cases. The first live case will be cryoablation with Transseptal access system from London. Concomitant AF ablation and LAA closure from Milan. And AF ablation with a novel flex tip, contact force ablation catheter, also again from London. Remember, Rio 2022 is supposed to be interactive. Again, live polls and audience questions. So please do not forget to submit your questions in the broadcast platform and interact with us. For the first time, we have the possibility for you to come on screen and ask a question live. So please submit your question and we will select a few as we go. So I ask you to get involved. We would like to thank our industry partners that enable the free to access nature of this rhythm event. Headline partners, Boston Scientific and Medtronic. Partners, Abbott and AtriCure. Supporting partners, Biosense Webster, EBR Systems, and Volta Medical. Right, without any further delay, let's get into session 1 of Rio 2022. Welcome everybody to this first session of day 2 of Rhythm Interventions Online 2022. We have got a great session in store. Cryoablation with Transseptal access system performed by Richard Chilling and his team in London. Before we join our case center, I am more than delighted to welcome our fantastic panel. We have Luigi Di Biase, New York, United States with us. James Freeman, Connecticut, United States. And Andreas Rillich, Hamburg, Germany. As with every session at Rio 2022, we are live. So we want you to get involved by submitting questions to us, and we will address as many of them as we can. So let's move on. Without any further delay, let's hand over to Richard to London. Hello, Richard.
Hello, hello. Thank you for joining us in London.
Yeah, we are very much looking forward to what you prepared and will perform for today's first case.
Okay, so I'll tell you about the case and explain what I'm hoping to do during the case. So I don't know whether there's any slides showing. I can't see them if they are, but here we go. So as you said, Julian, we're going to be aiming to do a cryo AF ablation with the new AccuCross Transseptal system. And these are my disclosures. And what I'm hoping to cover, if we go to the next slide, is firstly she's a 73-year-old female. She's had persistent AF, which then cardioverted itself with the help of amiodarone, having failed all other antiarrhythmic drugs. Her only risk factors are she's a bit overweight. She's got good cardiac function and a normal echo. And when she told her 13-year-old grandson about this, they were very excited that her private parts may be transmitted throughout the meeting, but I reassured her they wouldn't be. So her 13-year-old son was looking forward to this. So the topics I want to cover, I'm going to be really aiming at a very basic, simple level to try and get across tips and tricks, as well as covering the AccuCross transseptal technology. So I'm going to talk about the pre-op discussion, the femoral puncture, the transseptal approach, how we localize the catheter, and the closure and post-op management. So for the panel, this will be far too basic, but I hope for some of the audience, they may get some benefits from this. So the immediate pre-op discussion, the topics I cover with her are firstly the things that she needs to look out for afterwards. And these are specifically to expect chest pain, because if they don't expect, then it's much worse than they would normally experience. So they know to expect chest pain. They know to expect some AF in the first few weeks after the procedure. I tell them about the rare visual migraines that some people may experience, because if you don't, even though it's rare, they think they're having a stroke. So I warn everyone about that. And I tell them how they can stop any leaking from their groin if they do have a leak after they've gone home, and explain just gentle pressure for an hour over the site will stop that. Otherwise, they'll call an ambulance and end up in A&E with a big bruise. I'm going to talk you through the other things I warn them about is because this lady's under nice sedation, thanks to our lovely sedation nurse, Marion, she will experience some symptoms during this, and I warned her about that. So I warned her about the ice cream headache and the hiccups she would experience with the phrenic nerve pacing. And I find if you warn people about that, they find it much more easy to tolerate when it happens. So we're going to talk about the femoral puncture. But before we do, I'm just going to show you the AccuCross transseptal system. I don't know whether we can get a camera on here now. So essentially, it's the Medtronic FlexCath sheath, and the AccuCross replaces the dilator. And so you don't have to do any exchanges with the dilator. It also comes with a guide wire that goes through the end of the transseptal there. So I'll be putting it up on the guide wire it comes with. When I'm at the correct location, then I can advance the needle, which is integrated into the system. And if you focus on the tip of the catheter just here, you might just see that little needle pop out in and out there. And once that's out, I can then pass my guide wire through the needle and into the left upper pulmonary vein so that I know I can advance the sheath with impunity, not worrying about it going through the, I'm going to put it on a dark background because I think it's a bit difficult to see otherwise. So sorry to the cameraman. So one of the problems with the RF needle is it's very good at getting through the septum, but it doesn't obviate the potential danger of advancing the sheath too far and getting it through the appendage. So the benefit of having a guide wire through, hopefully you can see that popping in and out there. So the benefit of having a guide wire through is that the guide wire will, as long as the guide wire is outside the heart borders on the X-ray in the AP view, you know that the sheath will follow that and will not go through the left atrial appendage. The other tip
Richard,
and trick that you'll see me do.
Question. How many of your cases are you typically doing on a same-day discharge basis? And what is typically, or what have you been doing so far with regards to the transseptal punctures? So do you see this specific transseptal system especially designed for the patient population for same-day discharge? Just your general thoughts and on this.
So all of our patients, almost all of our patients are same-day discharge. They all have uninterrupted anticoagulation. So she took her apixaban this morning. When we get wire access, we'll give her 10,000 units of heparin. And then we'll talk about the closure and post-op management close to the time, but they'll all go home. As long as they finish in decent time, then they'll go home later on that day. This lady's traveled 350 miles to get to us today. And so she's probably going to be staying in a hotel or with friends and family tonight if she does go home, if we finish in reasonable time. So she's come up with her husband and we'll go home later on tonight. And we'll I'll show you the stitch and how I use that in a little while. One thing I was about to say is when we push the sheath through the septum, I'm continually, you'll see me at the back end of the sheath, just joggling the wire back and forward to make sure it's running easily. Because if it's not, it means that the wire at the other end is potentially being kinked or pushed up against the roof. And so you're pushing too hard if that wire's not running back and forward easily over the through the sheath. The sheath isn't tracking over the wire. Right. So we're starting very basically, and I'm going to show you the ultrasound and the femoral puncture. And I use lignocaine or lidocaine on the needle that I'm going to be accessing the veins with, so that I can put lidocaine all the way down to the vein itself, so it minimizes the risk of discomfort. Now, interestingly, if you look at can we see the ultrasound now? Yeah, so you can see here the vein, which I'll compress, is right behind the artery. If you go up a little bit higher, you'll see it swings out from underneath it. So if you go too low, it can be difficult to get to the vein, but as long as you're puncturing high enough, the the vein will come out from behind the thing. Now, as I put the blebs of local in, you'll see them showing up on the ultrasound. So it's a really nice way of confirming where the end of the needle is.
Yeah, we can see that nicely. And may I ask Andreas from Hamburg, Andreas, are you using ultrasound guided puncture on a routine base? Did it make it to your lab, or are you still doing conventional?
Well, thank you for that good question, because we indeed started 3 or 4 months ago. So we implemented the ultrasound for femoral puncture in our lab. And to be honest, we do that on a routine basis every single day in every single case, in SVTs, in VTs, and in AFib procedures. And we have the same experience as Professor Schilling demonstrated right now. So there's a couple of veins which are directly under the femoral artery, and it's more or less impossible without the ultrasound to identify this location. So I personally believe this makes a lot of sense.
If we can show my hands as well. So I'm right on top of the vein now. So I'm now going to abandon the ultrasound, and I'm going to hold onto the needle with my left hand and then just gently advance it, because I know I'm on top of the vein. And then that left hand helps to stabilize the needle while I get into the vein. It's quite a small, low pressure vein, so I'm just finding the right.
Luigi, I believe, or I would assume that you are also using ultrasound guided puncture in your lab. Did you observe, if so, did you observe a change, or you're smiling, or are you still sticking to the good old without puncture, I can do at school?
I'm smiling because when we start talking about using this, I got the opposite response. We don't need that. That's a waste of time. We can do it without. And a few years later, 4 or 5, I now see that this technique has been adopted worldwide. So I was smiling because the same thing that we have been telling about transseptal access guided by ultrasound, that one has not been implemented yet, but the femoral vein has been implemented. So I'm just saying that every time you can see what you're doing is always better and safer, and allow you to have all procedure at the same safety than normal anatomy versus abnormal anatomy. So for sure, watching is that. And also we recommending the use of this type of guidance because we first recommended uninterrupted anticoagulation. And with uninterrupted anticoagulation, either with warfarin or NOAC, you know, the access is extremely key to avoid a growing complication.
Yeah.
So just one minor point that I'm only going to use a 7 French sheath for the phrenic nerve and the flex cath. So I put the first sheath in without a blade puncture and then made a blade puncture just above it. So because I knew exactly where I was going to put my second puncture. And that means that you're definitely going to go through the site of the blade puncture and it's just a little bit easier and you only need one puncture because the smaller sheath will go through that without any problems.
But did I understand it right, Richard? You're using 2 sheaths for this cryoballoon PVI case?
That's correct. One for the cryo balloon and one for the wire to pace the phrenic nerve.
Yeah. Okay, perfect.
Yeah. It's worth reiterating what was said earlier. That the anatomy can be really variable in people. So the ultrasound just has great utility in terms of just being able to individualize the anatomy. I was curious, are people using micropuncture or standard Cook needles for their access? What bore needle are people using?
So if I saw it correctly with Richard, he used the regular puncture. But maybe Luigi may use a micropuncture needle. I don't know, Luigi?
No, I actually, there are a few people in my group that use the micropuncture. I think it's an extra step of wire exchange. I use the traditional Cook needle guided by ultrasound. You can see the needle. I like to go very perpendicular and I don't like the micropuncture, honestly.
Yeah, okay.
The same in our
So now we have 2 sheaths in, perfect.
Right, yeah, so one point I just wanted to show you is for the younger trainees, the trick to putting these big sheaths in is not to push them hard, but to gently screw or drill them in, particularly through this sort of tough bit of tissue just under the, just above the femoral vein. Otherwise, you kink the wire. And the transition for this dilator is a bit better than the Medtronic one, so it's already in. And you can just see I'm checking the wire hasn't kinked. It's running back and forward nicely. And so now the sheath is in the venous circulation. So we're going to do a quick flash and make sure that the wire's up in the SVC in just a second. And we'll have X-ray on now, please. So the next step is to get the sheath up into the SVC, and then we'll go to the LAO view. And of course, I've got no wires or needle to exchange because it's all in there already.
Richard, just to reconfirm for our global viewers, so you have fluoro, you don't have a TE probe in right now, you don't have an ICE probe in right now, so it will be primarily fluoro-guided to puncture, or what additional imaging are you using?
Just fluoro imaging. Under GA, I'd use TEE, but this lady's on sedation, so we're just using fluoro, and we don't have ICE. We do have ICE, but it's very limited in our access because of the cost. So I'm now going to just pull the guide wire back into the needle and sheath. And can you, yeah. So the key landmarks I'm interested in, we'll come down further north, is the left atrial appendage and the spine. And that's where I'm aiming to point my, just pull the table over a little bit. And I'm just going to do a quick shot to make it easier for everyone to see. Just push away a tiny bit there. That's lovely. So now there's the spine. You'll see the left atrial appendage is just this sort of bulge on the top right-hand corner of the X-ray screen. And I'm now going to drag the sheath back. And if you listen carefully, as I drop into the appendage, we may hear ectopic beats. You just heard that ectopic beat as it comes into the appendage. So I know I've part of the way there. Now I'm looking for it to drop and you see it drop onto the spine, and that's where I'm really aiming to make my puncture. Now, if you put the camera on the needle itself, what you can see is it's naturally sitting at the right place. If I let it go, we may even see a little bit of cardiac movement there. You see it little moving. And if you imagine dropping a cannonball onto a trampoline, the cannonball will sit in the middle of the trampoline. It will want to self-center. And the same for these, the fossa is the floppiest bit. And so the needle will tend to want to sit in the middle of it. And so as long as you don't force it one way or the other, then usually you should be okay. Anteriorly of this, you've got the aortic root bulging into the septum. And so you have to work pretty hard to turn the sheath anterior to get through into the aorta. And posterior, of course, you've got the posterior wall of the left atrium. So I'm happy that we're at where I want to be. I'm going to then just advance the needle and then explore gently with the guide wire to see if that then runs into the left atrium. And I'm using my fingers very gently with the wire just to not put any force on it. So if there's any resistance, my fingers will slide over it. So I'll do this with X-ray just so you can see what's going on. So I'm advancing the needle with my left hand. And there's the wire gone in very nice and easily. However, and I'll just take a shot just in case you can't see it terribly well.
Yeah, it would be
However,
helpful
it's not going
to see
outside
it clear. Oh, yeah.
Now, it's not going
much
outside
better
the
to
heart
see.
border. So I wouldn't advance my needle, my sheath or my needle now. So the needle's back, it springs back when you let go of it. But I want to guarantee that I'm not in the appendage and I'm not in the pericardium. So what I'm going to do is pull the wire back a little bit and turn the rig clockwise and see if I can get it outside the heart border. And we can go to AP, it'll be easier to see there. And now it's outside the heart border. So I know that when I advance this sheath, the only place I can be with that wire is in the heart and the left upper pulmonary artery, left upper pulmonary vein, sorry. Everyone, can you see that okay, Julian?
Yeah. If you do the extra shot with the fluoro, it was very clear to see. Maybe you can do it again. Yeah, thank you. Oh yeah, now we
Okay,
see
so
nicely
now,
the wire running out. Yes, perfect.
Yeah. So now what I'm doing is just putting gentle pressure on this sheath. And if you look at my left hand, I'm just moving the wire back and forward gently. And if I can move that easily, then the sheath is tracking the wire. And I'm just feeling the pressure build up on that dilator. And it's already making some advance through the sheath. Sometimes you feel a sort of sudden give, but I haven't felt that in this situation. But it's gentle pressure rather than a sudden push. And just being patient, it will eventually just flop through. Oh, that's my.
While you are doing this, Richard, we will ask our very first questions to the audience. This is a question you prepared. What, in your view, the audience, is the most hazardous part of cryoballoon AF ablation with current technology? Is it A, to obtain the vascular access? Is it, or number 2, is it the transseptal puncture? Is it number 3, extra cardiac nerve damage to the phrenic or to the esophageal? Or is it number 4, esophageal damage or fistula really? Or is it number 5, pulmonary trauma? Or is it maybe number 6, same-day discharge? While we vote, I think we will go over and watch how far we got with the sheath.
So what happened, Julian, is that the sheath got a little bit stuck. And so what I did is just turned it clockwise and anti-clockwise just to gently screw it through the septum. And now we've got the sheath in the septum. One thing I forgot to mention, if we can go on the camera, is that if you are having problems getting through, I think this is the only integrated needle that actually has a RF capability. So there's the wires that allow you to connect it to a life force diathermy unit and use RF to get through. I don't tend to use it, but it's a nice added extra if you need it.
And in your experience, how often do you need to use that option?
I've never, I'm just not used to using it, so I never use it, but I know that it's very popular in the US.
Yeah, maybe I can ask.
Tip for the fellows. Sorry, one tip for the fellows, always aspirate your sheaths and then re-flush every time you take something out. And we're going to flush both lines while you ask your question, Julian, and I'll pass the balloon up.
Yeah, perfect. I wanted to ask Dr. Freeman, how are you using, or are you very familiar? Do you rely on RF to cross the septum?
Yeah, so we universally, almost universally, I would say we have one or two providers that are still not using RF, but most of our providers now are either using an RF needle or the integrated VersaCross system with an RF delivery wire at this point.
Yeah, and another question to you, James, would be, we have seen that Richard was doing it on a fluoro-based Transseptal. Of course, he is an expert. He exactly knows what to do, and we learned a lot from the fluoro. What would be your approach?
Yeah, so I think Luigi was referencing this earlier. We, we definitely use ice for all of our Transseptal procedures. I think it's financially a little more viable here in the US, and we've certainly heard that other places where they do it expertly with fluoro, but that's been our practice. And, I would say going back to the RF wires and needles, I think it can be particularly helpful for left atrial appendage occlusion, where you're really trying to guide exactly where on the septum you're going, and it may not be the weakest part of the septum. It may be a very low and posterior position, for example, or a low and anterior position. And so in some cases, when you're trying to work on the periphery of the fossa, it can be helpful to have RF, I think, in that situation. Similarly, I think, ice imaging can be really valuable in that context. And so we've found it valuable. We have published data, particularly on the use of ice and, the benefits in terms of safety. So it's something to consider if you're in a context in which it's a possibility as a safety measure. All
right, thank you. Let's move over back to Richard. I think you already introduced something.
So I do a lot of ablation in a day surgery center where we don't have overnight beds, and there we do everything under GA, which means I can do a transesophageal guided transseptal, which is an added layer of comfort. So it's always nice. And I've learned a lot from what the transesophageal images look like as to how to expect them to behave when I'm not using ultrasound. So let me just show you the barred signals now. So if we can go to the barred signals, I haven't done any fluoroscopy yet. I know my sheaths are cross in the left atrium. As I gently advance the wire out, I can see that there's a signal. And if I advance the wire slowly, that signal disappears. So I now know that I've gone up the left upper pulmonary vein. I haven't done any X-ray yet. I've advanced my balloon to the tip of the sheath. There's two markers here that tell you where you are. And now I can hold onto the wire with my left hand and just advance the balloon out. And all the time I was moving that wire, I was making sure it moved freely. I wasn't, I was not allowing any resistance to occur. If there's any resistance, I'll stop and I'll X-ray. The signal on the bard's gone completely. So if we inflate the balloon, Rex, and I'm going to let that balloon come up, and then I'm going to just oppose the sheath against the balloon by just separating them slightly, and then just put a bit of gentle forward pressure with my left hand. And then I'm going to inject some contrast to get rid of the saline and the blush. And then, having stopped injecting, I'm going to take a look. And there you can see I've got occlusion, but the balloon looks too small. So I'm going to deflate it again because I don't want to inflate there. Can you freeze there? Can you deflate again? I don't want to.
We could not see your fluoro. We just saw the electrograms.
They should be able to see the image if you switch to the fluoro now, guys. Can we have fluoro? I don't want the cryo screen, just the fluoro and the barred signals, please.
Now we have it, yes. Andreas, what is your comment to that? What would you do?
Well, so what we would, or what personally I would do is whenever the balloon is in, well, not perfectly in shape and looks a little bit well, condensed, I would pull back maybe. I would maybe leave the balloon open, pull back a little bit, and keep the sheath close to the balloon. So whenever it pops out of the vein, to be sure that I can control the balloon. That would be my approach, but it's also reasonable to deflate the balloon and reposition it.
So the clue was that the balloon was up, but we didn't have any signals on the PV wire. And the wire, if you look at the barred signal, so I pull the wire back very slightly, you can see that 7/8 gets noise. So it's right at the very, it's only just out of the balloon. So I pulled the balloon back further. I haven't x-rayed again. We inflate again. But the reason I'm inflating now is I've now got PV signals. So that suggests the balloon may be now sitting outside the vein. I'm going to gently
still
just push
see
the
a
balloon forward
reference
again.
screen. Would be good if you see the live screen for the fluoro.
Haven't done any X-ray yet.
Okay.
This is all off X-ray. So this is all being guided by the signals.
Yeah, the signals are very small. We can't. Yeah.
Can you? Yeah. So
yes, now it's better.
So
the signals increase. Yes.
So now I'm going to inject again and just take a shot on fluoro. Because we have the fluoro again, please. And there's no dye hang up. So I'm going to push a bit harder. The balloon looks fully inflated, but there's no dye hang up. So I'm pushing a bit harder. I'm injecting a bit more. And when I've stopped injecting, then I take the shot and there's the dye hang up. So I know that that's hanging up, not because I'm injecting, but because the balloon's blocking the vein. Can we inflate there? Sorry, yeah, freeze there. And we go to 180, please. And then can we go to barred big screen on the barred for everyone to see the signals? So I'm holding on to this balloon and putting forward force on it while it inflates, because it gets a bit bigger when you start putting gas through it. And so you have to hold on to it, otherwise it'll slide out and stop blocking. And I've got a pretty quick drop in temperature. So I'm at -32 already. We're looking at the signals to see if there's any delay. And I think they are beginning to delay. And I hope we're down to -45. It's beginning to plateau, but I think those signals, I think they've gone, haven't they?
It did change. Now
yeah,
I can't hardly see it.
Come back a little bit more. I'll show you the review screen in a minute, but yeah, so it slid into the ventricle and then disappeared. It was pretty subtle. It was a big atrial signal that looked a little bit like the ventricular signal, but it's I'm happy that that's actually isolated, and what we're looking at now is far field. Now I can let go of the balloon and I can put my quad up to the SVC in preparation for pacing. So I keep myself busy while we're waiting for that 3-minute freeze to finish.
What was very elegant, I think it's also a good, very, let's say, simple, but nice technical tip, which you showed to us. Once you have the position of the left upper vein, you don't have to keep it with your sheath, and therefore you don't have to refine it later on, and you save obviously time and also efforts. So I think that was also a very good learning point. But still, Richard, why don't you just simply leave the wire or the spiral catheter inside of the vein and inflate the balloon within the left atrium, and then just simply push instead of the first move you did?
Normally I would, but the balloon was just a bit too far in, to be honest, and I just misjudged how far forward the balloon was. If you'd watched the signals, I'd actually got the quad up into the atrium and then maneuvered it up the SVC just by wobbling it left and right, and the signal disappeared. So I think I'm in the SVC. I haven't taken a look on X-ray yet, but we'll have a quick look on X-ray. And there it is. So I was just using the electrograms to guide me up the SVC. I hadn't actually used X-ray. And then we'll pace the quad, please, and I'll see whether I can get phrenic nerve capture. And while I'm doing that, maybe we could show the balloon profile temperatures for the audience. Can we show the cryo console image? So there's the temperature. So it's a pretty good temperature profile. It dropped pretty quick and it went down to -54.
Yeah, very nice. Very good temperature curve. Luigi, I know you are using, of course, American guys. You guys here very often use ice. Just a brief comment from your side, ice with regards to positioning of a catheter at the target area to identify also fluoroless or without fluoro, just a few words.
Yes, I think ice is very important because first of all, for junior generation, they are trained to do the whole transseptal access and mapping fluoroless completely. For older people like me, I still use minimal fluoroscopy while I do my transseptal because that's my habit. But I have trained a few fellows that are able to do it without, and I almost moved to no fluoro myself, despite still the fluoro sticks into my mind all the time. So ice for sure allow you to do the whole procedure with the same ultrasound machine, start with vascular, then after vascular access, switch to ultrasound. We do a reconstruction of the heart, and then we do the transseptal completely fluoroless. Number two, the transseptal is key. Richard is a very experienced and skilled operator, but in general, if you have to ablate the pulmonary vein and you are using a point-by-point catheter, but I think also a balloon, you want to reach properly the right inferior PV and the right superior PV. And so you need to have a posterior stick. So some heart are rotated. Not everything is as simple as in a standard case. Ice allow you to stick posterior and to move your catheter in a way that you can easily get good contact and easily achieve the pulmonary veins. I think as a standardization of procedure, the use of imaging allow that to happen.
Right. Thank you.
So
Richard, how far are you?
Well, we're running. I've stopped because I want to show you all these maneuvers. So can we show the hands and the signals? So I'm not, and show the barred signals as well. So show small hands and big barred. So I've not x-rayed again. I've pulled the balloon back into the sheath and I've got the wire completely out of the sheath, and that's my safety. So having the wire out means that you're less likely to cause any scratches or tears. And I've left the sheath completely straight. And then I'm going to turn the side arm so it's pointing to where I think the right lower would be, which is usually about 8 o'clock on the clock face. And then I'm putting deflection on the sheath. And if you look at the signals on the wire, you may find those signals begin to drop off as the wire drops into the right lower. And then if I advance the wire out, no resistance there, I've got no signal. So I think I'm now in the right lower. I haven't taken any x-rays yet. Let's have a look and see whether I'm right. And there you go. So it just shows you how much you can do by just using the clues from the sheet.
Can you show the fluoro? We cannot see the fluoro at this point in time.
So that was just one frame shot I took of the confirming that's where it is. And then we're
wonderful. That's very, very nice and very beautiful to see. Fantastic. Let's go over the polling results, which we asked in the first question. The results came in. What was your view in the most hazardous part of the cryo AF ablation with the current technology? And the predominant numbers of audience voted for the transseptal puncture. And I believe you beautifully showed how to manage this very, very professionally and very, very safe. So yeah, the point is very well taken. And therefore, I would like to move on with the next poll question, which we prepared. The second question would...
Before you do, I just want to quickly show you this before I start freezing. So when I inflated the balloon, the signal suddenly got bigger, which indicated the balloon had slid out. And then when you can see the X-ray, can we show the X-ray in small there? So signal's big, X-ray small. And you can see the balloon has slid back and is outside the vein. So I've just pushed it forward. And I'm going to take another little quick shot. And there I can see dye hang up. So I'm ready to do my freeze while you do your next poll. Freeze there.
Yeah, fantastic. That's fantastic. Okay, the next question for our audience would be, maybe we bring up the next second poll questions. For patients undergoing a first-time persistent, as in our case, AF ablation, with a duration less than 2 years, what is your preferred strategy? Number 1, cryo PVI. Number 1, RF PVI only. Number 3, PVI and linear substrate ablation. Number 4, PVI plus mapping driver ablation. And number 5, substrate ablation alone. So please vote, and we will go back to Richard and watch what he has achieved so far.
So we've got a nice ball forming on the wire, so you can see how far back the wire is. There is delay.
And you continue pacing the phrenic.
We're still
you
pacing
see
the
map?
phrenic. So we've got a little diaphragm signal there, and I've got my hand on the tummy as well. But this vein isn't isolating, so I'm going to try again with a better position because, oh, it's just gone.
Yeah,
I must say that I don't try.
What was time?
Yeah, it was a long time to isolation, but I don't try that hard with the right low because I know it's bloody hard anyway. I've just pulled the balloon back a little bit, and if you look at the cryo profile, I don't know whether you can show the cryo temperature. Yeah, you can see there's a sudden drop. So there was clearly a leak on the bottom end, and when I pulled the balloon back slightly, it closed that off, and suddenly the temperature is looking much better. So actually, I'm going to continue with this because the temperature isolation is much higher than the temperature I finally get to with the balloon. So I'm happy to continue this one now.
Andreas, what is the value of maneuvering and pulling or playing around with the balloon in certain positions? Would you do the same, or what would you do? Would you continue?
Yeah, I think I would do the same. So it's very reasonable to wait for the first freezing part, maybe for the first minute or for the first 80 seconds, and to see what's happening. So the temperature was developing not so bad, and it was pretty clear that whenever he pulled back that the sheath and he pulled down the balloon, that there was most likely a gap closed. I would have done the same. So maybe before the freeze, what I personally do is I usually use 2 different angulations. So I start in REO, particularly for the right inferior vein, REO 30. And whenever I've opened the balloon, I've checked in REO, I usually go over to LAO 40 for a quick look and see how the alignment is, the alignment of the sheath, the balloon, and the sheath catheter. So for me, this I believe this is very helpful to be sure that the balloon and the sheath are on the same line. So that's what I usually do before I freeze.
Yeah, I couldn't agree more. What we typically do, we pull it down after 1 minute, and we give us another 20 seconds. And if it's isolates within that 20 seconds, we are very happy. If not, we may reconsider repositioning, doing similar maneuvers. But yeah, Dr. Freeman.
So
I see that Richard's using angiography. I'm curious, are people using pressure waveforms to look for occlusion with the balloon? We've been using that with success, and again, allows us towards the goal of minimizing fluoro. So I'm just curious if others are using that.
Sorry, guys, can I just interrupt for a second? I just want to show 2 very quick points before I shut up again. So the cryo, the quad was too low. If you look on the X-ray, I'm not convinced it was high. It was sufficiently high for the right upper. So after we finish freezing, you inflate the balloon, please. After we finish freezing, and then deflate, please. I moved it up while still pacing, so I've got it in position for my next one. Now for the right upper, what I've done is I've straightened up the catheter, the sheath. I've turned the side arm pointing to where I think the right upper will be, and I'm going to put a little bit of bend on it to give it steerage. And then I'm going to see if I can get the wire up the right upper. There's signal there. And then if I push further on, the signal goes. So hopefully I'm in the right upper. And there you go on the X-ray. Can you show the X-ray? So that was one flash of X-ray. I didn't show any X-ray. That was all done without X-ray. And the X-ray was just at the end to confirm that's where I am. And again, you can see on the side arm, if we look at the hands, it's pointing to where the right upper would be, as opposed to the right lower, which is that way, which is why I don't use any REO or LEO, because I know that the sheet is telling me where I am in terms of angulation. Can you inflate, please? And then for the inflation, I'm going to just put a little bit of bend on the sheath so that when it pushes towards the vein rather than away and up to the left upper. I think there's a bit of dye hang up there. I'm just going to give a little bit more dye. And I think there's dye hang up there. So I'm going to pull the wire back. I think the balloon is a little bit compressed on the X-ray. So I've eased off that. And also I can't see the signal on there is really small. So I'm coming back with the balloon a bit because I don't want to be near the phrenic nerve. So I'm just repositioning the balloon a little bit just to see if I can get it a bit further back. And the wire is not showing any signals. Again, that's an indicator to me that I'm too far in. So I'm pulling the balloon back again. Now, the other situation that we might have here is that I've just done this vein and thought it was the right lower. I don't think I did because the angle is very different from the previous one. And I think I can just see a signal on.
So.
Yeah, and I can see a little bit of a signal on 1, 2. Can we inflate, can we freeze there and paste there? When we freeze, we might see that get bigger because the balloon gets bigger. And you can just about see
Richard,
that signal on 1, 2.
Yeah. Yeah, we see the signals now.
Julian or Richard, how much heparin did you give and what's the ACT?
So we give 10,000 of heparin. And generally, we don't measure an ACT during a cryo because they rarely go on beyond 40 minutes or so after puncture. And so we generally just give a standard dose of 10,000 of heparin. For her, if we go on longer because of the live case, I'm doing ACT and give a bit more to get it above 300.
Richard, I noticed you started with the left upper, then you moved over to the right inferior. You showed us very elegantly, basically without almost zero fluoroscopy. And what is the rationale to come back to the left inferior vein, probably at the very end? So I believe that set or zigzag course, there's a reason, there's an idea behind.
Yeah, thanks, Julian. So the reason is that while I'm doing the left lower, after it's isolated, I don't have to worry about phrenic nerve capture. So I can put my stitch in, I can disconnect all the pressure lines, and I can get the lab ready for the next patient while we're waiting for that 3 minute to freeze. So it just saves us a minute or two while we're, stops me getting bored.
That's a very good point. Actually, I thought you wanted to avoid temperature stacking in the esophagus because I also noticed you don't have a temperature probe inside and to have a time delay in between. But obviously, the left inferior vein, not worrying about the phrenic is also a very good point.
And also the patient's usually at their peak of sedation in the middle of the case. So we do the thing that's most uncomfortable, which is the phrenic during the middle and then leave the lower to the end. Are you all right? Do you want some more sedation? You okay? Yeah, that's the hiccups I told you about, yeah? Do you want a bit more? It'll only last another minute. All right, okay, well done.
And also, Richard, I mean, I have to admit, you do a single operator with the this Cryo balloon, and typically most of the centers would do a 2-operator procedure. So even more, not only saving time at the end, but also being very efficient as a single operator. So this is fantastic.
It's just because no one else wants to work with me.
I'll come next
I would
time.
have bet. Very good. With regards to the dosing, I noticed also you used 3 minutes. Do you feel comfortable with 3 minutes as a general, let's say, total freeze time, or are there any scenarios in which you would extend?
Yeah, I would extend if we maneuvered and found it took us a while to get the right position to get isolation. But other than that, I think we're all agreed we'd rather fail than cause a complication. And so, and I find patients post-cryo who come back with symptoms, I always feel a bit depressed because I know they've got a very high chance of having all those veins isolated. So the challenge is, what do you do next? So I'm pretty comfortable that the isolation is pretty persistent now with this 3-minute freeze.
Yeah, okay. And another question, I mean, being linked to our polling question would be, why did you decide to perform a cryo PVI in this persistent AF patient and not going for more, maybe beyond? And also then we may also involve the panel for that discussion.
Well, I don't think she's actually really persistent because she cardioverted with amiodarone, so she's sort of halfway between. But even persistent patients, I'd isolate the veins first and then worry about a more extensive procedure if they got recurrence. Before I finish this bit, I'm just going to show you the maneuver to the left pulmonary vein. So if you can, yeah, you got signals mainly and just my hand in small, please. So barred signals, that's it. So I've now got a signal. I'm turning my sheath towards the left upper. I've got the sheath completely straight. I'm pushing the wire out and I've got a V and an A there. So I'm just pulling it back and having another look. And that's probably to appendage. So I'm turning the sheath clockwise, advancing again.
Appendage.
I think it's still appendage, isn't it? So I'm just turning the sheath clockwise a bit more. I had one quick flash of X-ray and then confirmed it was appendage. Now I've advanced the wire again without X-ray. I think I'm probably in the left upper now. I'm then going to move, if we can show the X-ray as well, and X-ray and signals. So I move my sheath up to the origin of the left upper, and then I'm stopping X-raying. I'm putting a tiny bit of bend on the sheath and turning it clockwise, and then pulling the wire back. Now I get a signal as I come towards the back end of the sheath. If I then advance the wire out again, got a bit more V, I hope that that's now in the lower. And we'll look on X-ray and see if that's the case. And there you go, it's going down the left heart border. So I think that's the lower now. So you're able to do all of that without using any X-ray, just using the signals. Can you inflate, please? And there you can see the left lower pulmonary vein signal opposing the sheath to the balloon, as Andreas pointed out, pushing it forward a bit of dye in, and then let's see what that looks like. So I need to push harder with this, I think, because it's not occluded the vessel.
Again, we see the signals only at this point in time.
Can you show the X-ray as well?
Thank you.
So if we didn't see a signal there, I'd be thinking this was the left upper again, but it is going downwards. So I think it's just a big origin. We'll freeze there. And we're just freezing, and then that'll be the last freeze. Sorry, what's the problem? So
there's a technical question from the chat for Andreas Rillich. And Andreas, there's the audience wants to know your personal experience with the codec system and cryoballoon. Maybe you just comment on this.
Yeah, thank you for the question. So, well, the codex is a novel imaging system, and what we learned from the codex is that we can test our occlusion via an occlusion tool. So first of all, it helps us to navigate within the left atrium, and it helps us to visualize the veins. This is more or less our approach, that we visualize all the veins prior to the cryoballoon ablation in any case. Also, if we do it conventionally, we do the angios before, and with the imaging system, you can visualize the PVs and the branches of the PV, which is crucial to place the chief catheter. And the occlusion tool can give you the idea whether you have occluded with the balloon, yes or no, without fluoroscopy and without dye injection. So we can just inject saline, and the system shows you whether you have a full occlusion or not, or you have a partial occlusion. So personally, we believe this is very helpful. And for our approach, we say fluoroscopy by that, and we do it without any dye. So we have a zero dye approach.
And this became standard of care in your center?
Well, currently, we did the majority of cases with the system, which finally means that you need additional patches. So that's also a question of reimbursement, of course. But for the workflow, it's pretty helpful. You just do the map without needing a lot of fluoroscopy, and then you do not need any dye for assessing the occlusion. And we find that very helpful, yes.
Okay, interesting. So Richard, where are we now?
So we had, can I inflate the balloon? So I wasn't happy with that freeze. So we're just having another go at getting a better position. It's odd that the balloon is sitting quite low on the vein. Normally I'd sort of expect it to bridge up to the roof. So it's a slightly odd position for a left lower. It does seem to be occluding nicely though. And I'm still pretty happy that that's the lower. So let's freeze there and see if that signal goes now. We also had a low, the blood pressure was a little low because of the sedation. And one of the lovely things is that we've got a expert physiologist with us who just did a quick ultrasound and confirmed there was no pericardial effusion. So we're still happy that we're doing well here.
Yeah.
And she's comfortable and it's all good.
I just learned we have 3 minutes for this fantastic case still to go, and maybe we can bring up the result from the poll from the second question. And just one comment, sometimes to identify the left inferior, we like to change again the rotation from maybe LAO to RAO, and then you see the posterior runoff, and this tells you right away that you are in the left inferior PV. Okay, so the poll came in. And the poll, again, what would you do in persistent AFib? And the majority says and goes with you and go for a cryo PVI. Okay, that's interesting finding. Okay, so I think we now will have roughly 1 minute, and I would like to hand over, of course, Richard, to you to have your final remarks.
Okay, so we'll just spend a little bit more time sorting out this left lower. We'll use a stitch, and I stole a trick from Devi Nair where I use the 3-way tap to fix that stitch so that the nurses can then loosen it off on the ward. The patient can walk around, and if it's not causing any problems, they can just take the stitch out. If there is any leaking, they can then retighten it and give it a bit more time to stop it. This lady's been absolutely fantastic, and I hope she's going to get a good outcome from this. And thanks all to you and the team here for giving us your time and listening so attentively and giving such great suggestions and questions.
Excellent. Thank you very much, Richard, for this fantastic case, live case. And you did from A to Z within this 1 hour with a single operator, almost zero fluoroscopy, and even will probably discharge the patient back home today. So that was a fantastic learning experience. And of course, I would also like to thank you and your team back in London, but not to forget our great panel for joining: Luigi Di Biase, James Freeman, and Andreas Rillig. And I also like to thank the audience for tuning in, and keep tuning in because we will have a very interesting session following after this one in a few minutes. And I hope and we hope to see you there in a couple of minutes. See you then.